we are getting into a conversation this hour that's a combination of issues, social issues, health issues, and our good friends from KEMRI, Wellcome Trust, joining us again this morning in the person of Dr. Caroline Tigoi. And we're going to be looking at how children get infections that are resistant to treatment, a big issue in Kenya, in the region, and in many parts of the world. But she joins us this morning. Good morning, Dr. Tigoi.
Good morning to you.
How are you?
I'm fine, thank you.
Karibu sana.
Asante.
Do we say welcome to Nairobi, or are you in Nairobi? Or
I'm in Nairobi.
You're in Nairobi. Sometimes our friends from KEMRI are coming from different parts of the country, but we're glad that you've joined us here this morning. And we're going to be looking at an issue that's a big pain point for a lot of people, whether it's in the medical field or whether it's parents and their children. And so we're going to dive into that this morning. But before we do, we're going to welcome you to Kenya's biggest conversation. CT has a proverb. He goes to a different African country every week, and he comes back with proverbs. And I always say, like, as if you don't have enough work to do, we're going to put you to work this morning. And he's going to give you that proverb, and then we'd like you to interpret that for us and tell us what that meaning would be for you. Is that okay?
That's okay.
All right.
We are in the third largest country in Africa. It's called the Sudan. It's interesting. It's actually located in the confluence of the Blue and the White Nile. You know, what we call rivers here are probably streams. If you look at the Congo River, that thing is massive. The Nile, as it snakes up and goes towards Egypt, massive. Third largest producer of gold on the continent, Sudan. All this is marred by the constant conflicts. 7 times since independence in 1958, it has had coups and counter coups.
Yep.
The proverb from this beautiful country of Sudan: if your relatives are dogs, make a tail for yourself.
Wow. That's an interesting one. Yes, I'm not very good in proverbs, but I'll give an attempt.
That is all we require.
Yes.
And it's your interpretation. Don't think of what you think I want to hear. No, I want your interpretation.
So could you go again? You said...
I will repeat it even 10 times.
Okay.
If your relatives are dogs, make a tail for yourself.
So sometimes you could have so dogs like to bark.
They would definitely do.
And you have to, and they also wag the tail a lot. So you have to get to study them and get to know them and know how to survive, because they would like to make a lot of noise by barking. So you have to learn your environment and learn how to survive in your environment.
You have put it so well. Why were you hesitant? You are a natural interpreter of proverbs.
Thank you.
Fantastic. You got to learn how to survive.
Yes.
And it's always interesting how we can make the connection between what someone's interpretation of a proverb is and how we can connect that to the conversations that we have. When we look at the medical field and we look at infections, especially with children, these things have a way of surviving, from child to child. It's crazy. When children are home on holiday, everything is perfect. The minute they step into school,
yes,
they come back home in the evening sneezing and a host of other things.
True.
And then that whole thing starts to move and move and move. And that you'll find that, and I was saying it earlier this morning, you find that if you now should visit somebody else whose child was sick, you'll find that if it's in the same region, medical doctors or pharmacies are giving out kind of like the same medicine at around that time. You'll even find that it is the same medication or the same company that's being prescribed for these children at that time. Yep. So that's what we're talking about this morning. And we're looking at then, why do we see that infections amongst children are getting more virulent and that they are not then... they're actually now becoming resistant to treatment. Yep. So let's start off from the very beginning here, where we ask, what are these infections that we are seeing, and why do we see that resistance is actually building from treatment?
Okay, so to start us off, first of all, infections are very common in children because of their vulnerable immune system. And again, the challenges we have in the low middle income countries, including malnutrition. So whenever these children go to school, as you've said, clearly said, there's that opportunity to interact, and there's transmission happening, there's overcrowding in school, and therefore infections spread easily. But then again, there's a lot of overuse of antibiotics. These antibiotics are medications that are used for treatment of bacteria. But again, when we talk about school-going children, they get other infections that could be caused by viruses that do not require antibiotics. So therefore, we end up having overuse of antibiotics in our setting. So people do self-medication, as you've said. Some pharmaceutical companies would even be encouraging some doctors to prescribe specific antimicrobials because they want to sell it. But again, the challenge that we have with our children is that these infections sometimes develop resistance. So if you're overusing it, it means you're using it for an infection that you do not require antibiotics. If you have flu, for example, you don't need an antibiotic. So due to overuse, these bacteria are very smart. They develop resistance. They get used to the infection. Some people also use these antibiotics and they do not finish the dose. Or you use an antibiotic, a wrong antibiotic for the wrong infection and the wrong dosage. So then bacteria are very smart. They get used to these antibiotics and develop resistance. And therefore, that's the reason why we are having infections that are difficult to treat in our setting.
Tari, tell me, how do you get to understand as a simple parent what ailments to just tough out? You toughen it out. You drink water, drink porridge, drink soup.
Eat an orange.
Eat an orange, eat a banana, and run around the house 3 times. And then
put an onion in your sock or whatever.
Or something of that sort, yes, or put a balanced tomato on your head. When do you know that all you need to do is perhaps feed this child right, build the immune system, and when do you know that this child needs medication?
So we would discourage self-medication and therefore would encourage these mothers when they see their child having specific symptoms, especially when they are developing like fever. That's, I think, when you need to go to hospital. And when you get to hospital, we would also encourage the clinicians to test these children to confirm whether they have a viral infection or they have a bacterial infection before they prescribe an antibiotic. So what we are lacking in our current setting is that we do not have laboratories where we can test before we prescribe. So what our clinicians mostly do is just looking at the clinical symptoms and then they prescribe an antibiotic, which may not be necessary if it is just flu.
So this resistance to treatment, would you say that it is largely caused by human interventions?
Yes, it is caused by human interventions, and an example would be overuse in our clinical setting because we lack diagnosis. Number 2, we are using antibiotics for the wrong infections because, again, we have not confirmed whether it is flu or whether it is a bacterial infection. Again, antimicrobial resistance would come even from the environment. In our research that we've been doing in KEMRI, we've realized that even healthy people in the community would have resistant bacteria, even in their own gut. So we don't know when these bacteria gain entry into our bloodstream and cause an invasive, an infection that is going around in the bloodstream.
Okay, so then how do we know? Because I've heard, I mean, just having conversations with people, you hear some crazy stuff, Dr. But these are the things that people believe, we believe them. And then you go to hospital. I mean, I heard somebody say, mtoto wangu ni mgonjwa akona homa kwa tumbo. These are some of the things that we hear. And from a medical point of view, I don't know if that's something that's actually possible for you to have the flu virus in your stomach. But then many things come into play: cost, having to find your way to a medical facility. So you go to the closest chemist or pharmacy and you say, akona homa kwa tumbo. The person who is behind the counter could be none the wiser and says, okay, sawa, niko na antibiotic ya siku 3. You take it, and it's not even. How do you test? How do you be sure that what you are treating for has been properly diagnosed?
So we need at the moment to invest in diagnosis, which we are lacking in our country. So as you've clearly said, people go to the counter. We don't have policies that restrict the use of antibiotics in our setting. You just go to a pharmacy, over the counter, you're given an antibiotic. So the most important thing is to seek proper medical intervention from a clinician who would then, either based on their experience, because we've been doing a lot of awareness even in the hospitals to ensure proper prescribing, what we call antimicrobial stewardship training to clinicians to be able to tell when to prescribe an antibiotic. So I would encourage mothers or people out there not to go to the pharmacy if they have homa ya tumbo. I don't think homa ya tumbo could be viral, as you've said. It cannot be flu in the stomach, but it can be a viral infection that causes either an enteric or problems with the stomach. So sometimes it would be good to just do a simple stool test. Even a simple full blood count can tell you whether this person has a viral infection based on the immune responses that are happening in our body. So you can do a simple full blood count and be able to tell whether it's a viral infection or it's a bacterial infection that requires treatment with antibiotics. So diagnosis is very important, and it's something that our country needs to invest in. Yeah.
But Doc, as we talk about the resistance and all that, now there is the aspect of what we eat, malnutrition, and how these as well could be a factor of AMR. So then again, how do I know what to eat in making sure that AMR is not a factor? Because then again, maybe Nanja, I'll eat what I find.
So again, it's about training and awareness and working with the different departments in our ministries to train mothers on what to feed on these children. So if we have a healthy child, so why is malnutrition a problem when it comes to antimicrobial resistance? When you are a malnourished child, your immunity is low. It means you will be spending more time in hospital. And the way antimicrobial resistance spreads is that in the hospitals are sort of a hotbed of very difficult to treat infections. So hospital admission or being admitted in hospital is not a good thing. It's better when you are at home, because when you go into the hospital, you are a malnourished child, your immunity is low, you are going to acquire infection from the hospital environment. So it's quite risky. These children will spend more time in hospital because we are trying to do nutritional recovery. So as you've said, it's very important for our country to invest in food security, so that we don't have many malnourished children who would be dying in hospital because they've spent a lot of time in hospital doing nutritional recovery, and they end up getting a very resistant bacteria that is difficult to treat. And hence, one of the key challenges of antimicrobial resistance is increased mortality, which is mainly affecting vulnerable children and also neonates, because when children are born into hospital, their immunity is not developed. So some children actually are born malnourished or low birth weight, so they have to be readmitted. And when they are admitted, there are so many outbreaks of bacterial infections that are very difficult to treat. And we've seen even in our setting, up to 40% of these children die. When they are born and admitted, they die in hospital because they've acquired a resistant bacteria.
Can we take a step back?
Yeah.
The role of the mother plays, this is an expectant mother.
Yeah.
The role she plays in the health of this particular child.
Yeah.
The newborn.
Yes, what she eats, what she doesn't eat, if she currently has some ailments, the likelihood of this being passed on to the child.
Yes.
Drugs she uses.
So mothers play a big role in terms of transmission of resistant bacteria. Yes. So again, it would be, we are looking into research where we are trying to develop vaccines that we give to mothers so that we can prevent transmission to newborns during birth. So nutrition is critical, as you've said, so that we get healthy, bouncing children. But then again, there are some factors, biological, during birth, depending on how the child is being born. Sometimes the membranes are rupturing, which could make this newborn acquire infections from the fluids that are rupturing during birth. So if we have vaccines that we can give to mothers, then we can help prevent infections at birth.
How difficult and how expensive is it to set up a diagnostic system within the most basic of healthcare facilities so that one can actually know what it is that they're treating?
So setting up laboratories are very expensive, and because of the equipments that you need in place. So it is a very expensive venture, but what we have seen working is what we are calling the hub and spoke model. You don't have to have a laboratory in every hospital. In Nairobi, we could have one where we refer all the patients to go and get diagnostics. So if our government could have special laboratories within, say, the county governments where people can go and get diagnosed before treatment, that would be really useful. So setting up laboratories and ensuring that they are giving high quality tests and results that can be used for treatment is expensive.
It is.
Yeah, and that's why we don't have them at the moment, but we can have hubs that clinicians can be sending patients to get the results. And
I remember once upon a time in the previous century. No, it was in this century. When I worked for the Kenya Medical Research Institute, when we were testing people for viral load, where you were conducting the taking of samples, you didn't need to have a lab. The specimens were taken elsewhere.
Yes.
And you'd be told, come back after this period of time, you'll get back your results.
Your results, yes.
When you said that, I was reminded. And it worked very well.
Yes, it does work very well.
Yes.
Yeah. So if we have special labs, we invest in few labs that can do proper diagnosis in where people can have access to those laboratories, then we would really prevent the overuse of antibiotics before prescribing before diagnostics. So diagnostics is a very key thing to have. Against surveillance. When we have laboratories, then we are generating data and we are able to monitor what is happening. You see, bacteria are very smart. Today we'll have this antibiotic, and after a short time they get used to that antibiotic. Then we will need another antibiotic. So we need to monitor when these bacteria are outsmarting the antibiotics. Then we invest also in research where we are developing new therapeutics so that we have more alternatives, because we have at the moment there is no research that is ongoing to develop more therapeutics, so we have very limited number of drugs that we can use, and that's why it's very important to do prevention, first diagnose, prevent by having vaccines, and even creating awareness so that we are not misusing these antibiotics. Or, as you had alluded earlier, people would say, my neighbor used this drug
and it worked.
And it worked. So you go to hospital and you ask the doctor, I need this specific antibiotic, which may not be working for your condition. Or you go to your neighbor, or you share the antibiotic. Or you take the antibiotic for 1 or 2 days and you say, I'm well. So you are training the bacteria to get used to that antibiotic and then develop resistance.
Yet, when you talk about antibiotics and its misuse, it is information that one would expect that when you're going to the counter, because most of it happens over the counter, that the pharmacist, the person at the counter would be able to advise you backed up by policy. Yet it is a problem that does exist. Government has not come in place to give direction on use of antibiotics. But then brings the question on the responsibility of health professionals in making sure that antibiotics are not misused in the Republic. And that as well, I think I'll tie it together with when you talk about malnutrition, because the other day I did a story and it was all about even the foods that we feed our children, the porridges that the flour that we buy has a lot that ends up defeating the cause, because it has a lot of nutrients that end up being heavy metals for the child. So in terms of just communication and information that the public needs is missing.
Yes, we don't have information out there in terms of what the public can, in terms of what they need to So I'm not an expert in malnutrition, is a disclaimer. So I would say we need more public awareness on what we need to feed our children on so that they can develop better immunity. And what is important is also giving children foods that are able to boost their immunity, even just vegetables, just fruits that are important. Because if you're giving them porridge, then you are not giving them the full spectrum of what they need to build their immune system. Yeah.
Can you break down the science for us? Because a lot of times, if we don't understand the process, then it's easier for us to just actually go over the counter and use my antibiotics for 3 days. I feel better and I'm done. And even because we're focusing on children today, break down the science for us as to how bacteria then becomes resistant to treatment. Yeah.
So bacteria become resistant in different ways. So as I've said, they are very clever. So again, they would create like an armor, like a wall that would protect them from antibiotics. So they have a very thick wall. So I think when we did our biology, we knew that a cell has a wall. So we have a cell wall. So these bacteria would have a cell wall that is very thick and would not allow antibiotics to pass through.
Okay.
Yeah. Number two, they would also this resistant genetic material. So within a cell, we have DNA. So this DNA can move from one bacteria to another. So bacteria would have a vehicle that they use to transfer resistance from one bacteria to another. So you don't have to have, at the moment when we are studying antimicrobial resistance, we are just looking at this resistant genetic material. How do we prevent it from spreading from one bacteria to another? So it doesn't matter which bacteria is infecting you. You could even be having it in the gut, because our gut has a lot of bacteria as normal flora. They live there. But then they can gain resistance. If we misuse these antibiotics, they get to learn the antibiotics, and from the gut, these infections can move to the bloodstream and cause difficult to treat infection. So they have genetic material that can pass this information to another bacteria. Another way of developing resistance is that they produce so I have to break it down, because we call them enzymes in science, but they are sort of juices that can digest the antibiotics. So they break them down and make them useless. So some bacteria would have that ability, and they are actually the biggest and the largest and the most problematic bacteria that we call them gram-negatives. These gram-negatives can secrete enzymes that would break down the antibiotics, and actually these are the antibiotics that we call second line and third line antibiotics. They are sort of the last line. So these are the bacteria that are actually giving us a lot of sleepless nights thinking about how we are going to stop antimicrobial resistance in this group of antibiotics. So, so those are some of the mechanisms that they use.
Dr. Caroline Tigoi, a researcher with Kenya Wellcome Trust, and some of the conversations that we're having today, just around, treatment and infections in children, and how those illnesses have now become resistant to some of the treatment in the country.
Yeah, and as we talk about the AMR in the country, one of the most important aspects of dealing with it would be our investment in R&D, research and development. And we know that it is resource heavy and intense in setting that up. But just how critical is it in investing in research and development to be able to deal with this?
So research and development is very important, and it's an investment I would like our country to do, because we need to be able to track the infections that are happening in our setting. So what I was calling surveillance before, we need to be able to do diagnostics, and we are able to do more research in terms of checking what is circulating in our settings, because we've realized some infections could be endemic to a specific region. So it is only found in say in Africa, and again within Africa we sometimes find variation even in East Africa, West Africa, depending again on what we are eating, because the gut really determines what infections are circulating in our settings. So research and development is very important in terms of having capacity to do surveillance, having trained personnel to be able to do this and do some sort of analytics to look at projections on where we are going to. So when we track infections, we are able to tell what is the most predominant organisms that are causing these infections, and how are they behaving in terms of response. So we are able to test. If we have a specific bacteria, we are able to look at the antibiotics that they're responding to. So over time, we are seeing that infections are becoming more difficult to treat based on the resistant patterns we are seeing in the laboratory. So that research and development would be important in getting to know what is circulating. Another thing, it would be we are able to share this data even globally, so that as we are developing new therapeutics, new vaccines in the global space, people are able to know what is circulating either in Africa, because it's important for us to collaborate together and share data to be able to develop preventions for these bacterial infections. So research and development is very key, and training and capacity as well in our setting is very important, so that we have experts who are able to deal with these problems as they are emerging.
So how do children get infections that are resistant to treatment? How? Because I would imagine if a 5-year-old has been given an antibiotic, feels better after 3 days, and then, they don't finish. And that, from what you've told us, is a repetitive cycle. How does another child get that infection?
So it's through transmission.
Okay.
Because when we interact with one another, we get this resistant bacteria through even shaking hands. Hand hygiene is very important. Touching surfaces that are contaminated with this bacteria would cause these infections. So you don't know when you are infecting yourself by touching surfaces. So being exposed to environments that have these infections, being in contact with the people who would be having this infection, would predispose you to acquiring a resistant infection. And again, as we've said, children, their immunity between 0 days and 5 years, the immunity is still very low. So they are very susceptible to infections. So because they've not even done all the vaccines that we have available. Again, one big challenge that we have in our setting is vaccine coverage. We don't have, people are not going for these vaccinations, because if we vaccinate a population, then we prevent transmission.
Right.
So if the vaccine coverage is very low, because if we compare our country to high middle income countries, the vaccine coverage there is better than in our setting. So we need to create more awareness so that people can have more vaccination. Vaccine uptake is very important in preventing infections.
So
Why?
Okay, sorry. No, please. Go ahead.
No, do I insist? Please.
Really? Okay, let me ask this question, and then now it will come. Right. So how would you know, as either a researcher or a medical doctor or a clinician, that this infection is resistant to treatment? How would you know?
You have to do a laboratory test.
And you would be testing for resistance?
Yes, we test for resistance.
Okay.
So we first of all, if it's a blood infection, if a clinician is suspecting that you have a blood infection, they would take a blood sample, and then we do what we call blood culture. Once we grow an organism, then we test whether it's resistant. We have like a spectrum of antibiotics that we test against each and every bacteria.
Okay.
So we have guidelines that we follow in the laboratory to get to know whether bacteria is resistant or not.
Okay.
Yes.
Then you know what to prescribe.
Okay. So actually at the moment is a big problem. If you go to our public hospitals, our clinicians would be struggling, because they are able to see that this child has what they call sepsis. Sepsis is an infection that is in the bloodstream.
Yes.
So this child has sepsis, but I don't know what to prescribe, because, and again, especially in our newborn units, we've seen a lot of outbreaks and a lot of mortalities. So you find neonatologists or doctors who are treating neonates are really usually very frustrated because, one, they want to do a test in the public laboratory, but there are no reagents, there are no capacity to do the tests. So at the moment, it's a big challenge in our country. Diagnostics are missing, and the doctors are struggling to determine what antibiotics to give to these children. So you will find them just covering them with a broad spectrum antibiotic. And when you give a broad spectrum antibiotic, because you don't know what you're covering, then you're enhancing resistance.
Right.
Yeah.
Let me ask the question. 0 to 5, children have a very weak immune system.
Yes.
Okay. What is it that builds the immune? What makes it stronger after 5 years of age?
Exposure to the bacteria. So
Yes.
the more you get the infections, the more you build your immunity because your body reacts
Gets to understand.
by producing protection,
Yes,
which is immunity,
And how else do you strengthen the immune system?
by getting a vaccine.
Okay.
So if we have the vaccines that are available, we need to take them because that's when you're given, because vaccines
What is a vaccine?
a vaccine.
Because this vaccine seems to be the silver bullet.
Yes.
If you take the vaccine, you're good.
You're good.
Complete are good.
Yes.
You're even bulletproof. What exactly is a vaccine?
So a vaccine is so depending on
What does
the
it do?
organism.
What is it that is in the vaccine, and what does it do to your body?
So a vaccine is a bacteria or a virus that has been made less virulent. Yeah, virulent is it can't cause the actual infection,
less effective.
but it will trigger your blood system to generate what we call an immune response. So at the beginning you are at 0 level, but when you are given a vaccine, that is a bacteria that has been made less virulent, then your blood system will pick up protection to a certain level that would protect you from the same bacteria. So
Okay.
we make them, we make the bacteria less virulent, and then next time you have exposure to the actual bacteria, then you're able to fight it. Your body is able to fight it.
So essentially, the more your body gets exposed to bacteria and viruses, the more it develops its capacity,
To fight it.
these things.
Yes.
Okay, I'm going to park that there.
Yeah.
Now, food also helps. The type of foods helps someone build the immune system.
In terms of like fruits that have vitamin C.
No, I'm just asking foods,
Yeah,
whatever
food
they are.
and proteins that are
they
body
help.
building. Yes.
Exactly.
So we need
So-
to take proper nutrition is very critical in terms of our health.
So we're saying once someone has been vaccinated and they eat, whether it's a balanced diet or food that enables them to build the immune system, they should be less prone to falling sick.
Yes, they will be definitely. So if you're healthy, that's your normal BMI, body mass index, and plus you have protection from a vaccine, then you're less prone to infections.
Yes.
And we will prevent you from going to hospital where it's very risky, being in hospital. So we've been doing research where we've seen that many children would acquire infections in hospital. So you come into hospital with less resistance, and then because of exposure to contaminated hospital environments, and again, because you are given an antibiotic, you get resistance. So you come in with about 30% of resistance, and then you gain up to 70% in hospital. Then this resistance would also take about up to 6 months to go down to the level that we want. That is the current baseline in the community.
You say we should not go to hospital.
Yeah, Doctor, because I'm trying to imagine.
We shouldn't go.
The hospital is the
We
place
only
where
go
we
to
are going
hospital
to.
when it is necessary.
Necessary.
And at the moment, we're actually doing even clinical trials for clinicians. And in future, we hope it will inform policy, where when I go to see a clinician, before they admit me, they will have sort of a checklist. Is it really necessary to admit this patient? And if I admit, am I at any risk of dying? So if my risk of dying is very low, then I should send this patient home. You don't keep them in hospital.
Okay.
So simple interventions, even without any medication, just discharging somebody very quickly upon recovery.
Okay, just so
useful.
that we don't create doubt here.
Yes.
We are not saying, or are we saying, that hospitals, it is not the state of the hospital hygiene that we're talking about. We're talking about that there's so many people in hospital that you could actually get, children especially, could actually get another infection from. Or what are we saying here? Or is it a combined
It's
thing?
a combined thing.
Oh, really?
So one, overcrowding. Of course, in our setup, the infrastructure that we have creates an overcrowded environment. We don't have enough beds. Our babies are sharing baby coats. So therefore, if I have this bacteria, I would be able to give to my neighbor. Number two, our hospital, the infection control procedures that we have, how we reconstitute the disinfectants that we use in hospital could not even be the right, enough. It may not be enough to kill the bacteria that are on the surfaces. So we are saying in hospital, we have contaminated hospital equipment, we have contaminated hospital surfaces, contaminated even clinicians' hands.
Okay.
So if we are not doing enough sterilization of our hands or sanitization of our hands, then we are transmitting these infections from one patient to another. If our clinicians are not changing gloves, you use the same gloves on this patient, you move to the other one. You are also spreading the infection. So we need to do a lot. We need to do a lot of infection.
Do we see enough?
Procedures.
Do we see enough of infections being gotten at that level for it to be a worry point? Do we see? Can we trace it and say? And so I guess the traceability factor comes in here. That can you say this child being sick and another 1,000 children being sick and trace it back to a hospital setting?
Yes.
You know, and say it's because of this. So we say, hang on, folks, something needs to be done.
Yes. So I mentioned earlier, we are seeing a lot of outbreaks. Okay. So and how we do that is through surveillance or through children having the same symptoms. And that spike in same symptoms, same bacteria causing infection. So what we normally do is that we do environmental sampling. We collect samples from the environment, we culture them, and we tend to get the same bacteria that is circulating on the surface and the same one that is causing the invasive disease, like sepsis in children. And therefore, we are able to relate through genetic testing that these bacteria are similar. And it's acquired from a specific source. So usually it takes a lot of trouble to identify because you have to swab different services because if it is a neonatal unit, is it coming from the maternity? Is it coming from the neonatal ward? So we try and trace whether it's a specific equipment and actually, so hospitals are actually, as I said earlier, a hotbed for transmission of these resistant organisms.
And it would be actually, because people don't go to hospital for recreation.
No.
They go there because they're unwell. And they're unwell because they have things which aren't quite working, and so they walk with those things into hospital. So you look at the numbers of people who
are doing the same thing.
Of things. God Almighty, I must avoid hospital.
Me too.
And this is really, when you talk about just how we take care of ourselves on a normal day, if you go back to when COVID was still high, you remember the sheer fact that people are wearing masks, sanitizing, that lowered infections in the country. You find issues to do with gut health and whatnot. The numbers went low, which goes to show that if we just become our own agents in taking care of ourselves, just hygiene, cleaning your hands, making sure what you're eating as well, avoiding overcrowded places, it is one way of dealing with these infections. But Dr. as we talk about that now, there is now the issue of solutions moving forward. We know that we need more training facilities, we need more laboratories to be put in place, we need information to get out there. But what would be a recommendation as a researcher on what must be done in hospitals and what we must do ourselves just so we can deal with the problem, which is AMR?
So number one would be guidelines that we need to have in place, which could be through policy where we reducing prescribing. So we do a lot of what we call antibiotic stewardship programs, where we are educating clinicians on rational prescribing or less prescribing of antibiotics. So just prescribe whenever it's necessary. Number 2 would be creating awareness, public awareness, in terms of the importance of not just using antibiotics over the counter. Again, in terms of regulations and policy, we need to develop policies that would reduce over-the-counter use. So we have more stricter policies that would preserve some antibiotics. Even WHO have come up with a way of stewardship by categorizing antibiotics on those you can access anytime, and those that you would watch as you use, and those that you need to reserve for extremely severe infections. So if we could follow such regulations, such recommendations, then we would reduce antimicrobial resistance. Again, if we do more research, as we said earlier, R&D is very important so that we are able to track. We do surveillance and be able to know what is happening and what is developing so that we can do more of prevention. Again, if we are able to partner together. At the moment, I think everybody is working in silos, and we need to break those silos and have the different ministries working together, because we know, again, antimicrobial resistance would spread through environment, which could be through water, it could be through agriculture because of overuse of antibiotics in animals. So as I said, because bacteria can spread this resistance across, it doesn't matter, the bacteria that is in an animal can still cause infection in human. So if we can work together as using what we call One Health approach, the people in the Ministry of Health work with the Ministry of Agriculture to come up with ways of reducing the use of antibiotics in agriculture, then we would reduce.
Sorry, Doc, let me just get an interjector on this on this food, especially now we're talking about agriculture. So it comes to mind meat that you consume, or eggs, because we know that the antibiotics are given to these animals as they develop. So we are saying essentially, if you consume this product,
yes,
it's possible that you then can also get that resistance, essentially,
bacteria.
Or you can get the bacteria. So what are we saying? You can get the bacteria for which it is already resistant to treatment. Please explain that.
So what happens when we eat food that is already contaminated with resistant genes, then you are able to get it, because in our gut we have bacteria that are just sitting there and they are normal flora. So the food that we eat would predispose us in terms of acquiring antimicrobial resistance. So use of antibiotics in agriculture as growth promoters, like the chicken, even when we are doing breeding, then we are enhancing transmission of AMR. So in our gut we can acquire the so we've seen, research has shown that food would be carrying resistant genes. Yes.
So how do you avoid that?
I mean,
how would you know? How would you know? I mean, buying a chunk of meat or chicken, whatever. How do I know this bird? Because you talk about surveillance, and I know that's one of the things that KEMRI does. But do we have surveillance in the nation to the point whereby you can trace what has been put into this bird, for example, or what has been put into this meat, goat, whatever, and you can trace back and say, yes, well, antibiotics at an acceptable level have been used here, or that bacteria has not been traced at the time of slaughter, whatever. Can we do that?
Yeah, it's a conversation that we need to have, and that's why I was recommending multi-sectoral collaboration, so that we have people in agriculture reduce the use of antibiotics in agriculture, so that we can prevent transmission of AMR.
Okay.
So I don't think the policy is there at the moment. People really want, when you want to do agriculture business, then you really want to prevent infections in your flock, and therefore you would use antibiotics. So it's a conversation we need to have. It's something we need to do in terms of developing policies to reduce the use of antibiotics in agriculture.
Essentially, what I'm hearing you, Doc, say is if today I want to go buy, say it's a chunk of meat from my butcher, it should be able to give me what ought to happen is it should be able to give information on where he got that, who was the farmer who produced that, for me to be able to trace that. But that is missing.
It's missing at the moment.
Missing.
I don't think we have that, and nobody would tell you. I wouldn't tell you because.
Where does this happen? I mean, where do you go to a shop or where do you go to a supermarket and you say, okay, now just give me the history of...
In Kenya?
No, not in Kenya.
No.
In other countries it is.
No.
Yeah.
Is the history written? Is there documentation,
Yes.
even as you're buying it, so that you know they're telling you the history of this thing?
Yes. So they have the barcode, and when you click on whatever the
scan
barcode,
it.
It'll take you back to point of slaughter, inspection, who inspected it, all of that. It actually is available.
So essentially, in Kenya,
You can
if you had that
trace your
barcode,
food.
You could be told this cow walked from Kajiado.
Yes.
And I almost died halfway
and then boarded
through.
a lorry. And came to Ruben this day. You know.
And that's where the traceability comes, the
Essentially,
surveillance
that's what's
comes, isn't it?
Yes,
That you
yes.
can actually trace back, and that's why people are this food knowledge thing. People can actually trace back to the medication that was given to this animal at what point, in what quantities, over how long. So you actually know, you really know what you're eating.
Okay.
And it would even be better to keep you don't take it immediately. So after the animal is vaccinated, is given antibiotics, then I think there should be a time limit before you sell it to the population. Yes. So that calls in a lot for public health to come in and sort of protect the population. And it's still a conversation that we need to have.
These antibiotics in plants and animals.
Yes.
So essentially, when I eat certain vegetables and I eat certain meat, I'm eating antibiotics and I don't know.
Yes. It's possible.
Okay.
Yeah. And there could be traces also, because when we release effluent from hospitals or from agricultural or even through defecation, then we are releasing antimicrobial resistant genes back into circulation, like in water.
And
so
such.
We've seen traces of AMR genes in water as well.
I'd like you to wrap this up for us, and just, what would be your shot when you're telling parents who are taking their young children to hospital, telling others who are taking their, loved ones, food that we are eating. What would be the thing that you're asking us to remember or take into consideration today?
So prevention is very critical, because antibiotics are life-saving drugs that we need. And for us to protect our population, protect our neighbors, we need to use the antibiotics prudently. So what is important is that before you take any antibiotic, first of all, you have to seek medical advice. So you don't just go and treat yourself over the counter. We have to also take care of our nutrition. We eat well so that we are healthy, and we don't have to... We ensure that our immune system of our children is good. And again, taking vaccination seriously is good in terms of prevention of AMR. And so therefore, we need to work together. We need to enhance our hygiene, both at home and in hospital. So working together with the clinicians to ensure that we are doing a lot in terms of infection control. We are doing a lot of awareness, training ourselves in terms of which antibiotics we need to reserve for more serious infections. So we don't need to have access to all these antibiotics. We don't need to panic that we could be dealing with a resistant infection even before we diagnose. We need to use what we are calling first line before we move to second line antibiotics. Yes.
Important information that we all need to carry, front and center, not even in the back of our minds.
Yes.
And we want to thank you and our friends at KEMRI Wellcome Trust for having this conversation with us this morning. Dr. Caroline Tigoi is a researcher at KEMRI and has been our guest this hour. Thank you so much.
Thank you. Thank you very much for having me.
Thank you for being here. Asante, good morning.
This is the Situation Room, the only way to start your day.